Good afternoon, everyone. My name is Sophia Silo, and I am the Program Officer of the Special Projects Fund at the New York Health Foundation. We're here today to talk about an important lessons learned from the experiences of two community-based organizations who responded to the monkeypox outbreak this spring and summer of 2022. Before we begin, I have a few housekeeping items. We have close to 100 participants on today's webinar, and to ensure optimal audio and visual quality, we have turned off your microphones and your video cameras. We do want to make this as interactive a session as possible, so I invite you to drop your questions and comments in the chat box to the right of your screen. I'll be tracking all the comments on the chat and will try my very best to weave your questions into our discussion later on in the session. So the other thing I wanted to share is that this webinar is being recorded, and a recap of today's session along with copies of the slides will be posted shortly after today's webinar. Closed captioning is also available for those who choose to use it. And then finally, a quick word about terminology. The term monkeypox is deemed by many as a term that sensationalizes and stigmatizes communities of color and the LGBT+ community. MPV can be used interchangeably, and I will be using MPV to refer to the virus from here on in. Okay, so let's begin. The MPV outbreak came shortly at the heels of a global pandemic and once again required concerted effort on multiple fronts to respond to community health needs in a rapid and efficient way. Community-based organizations play an integral role in our social safety net, acting as a trusted source of information and as a hub for much needed services. We are joined today by Anthony Fortenberry, Chief Nursing Officer of Colin Lord Community Health Center, which is located in New York City, and Matthew Crean Higgins, Associate Vice President, Specialty Care at Evergreen Health, based in Buffalo, New York. Both are leaders and advocates in their communities, and we'll speak today about some of the lessons learned from their efforts to mitigate the spread of MPV. These are all very important lessons that can inform how we can be better prepared for future public health emergencies. Before we launch into our discussion, Anthony will first provide a brief overview of MPV as it stands in New York currently, and then I'll invite him and Matthew to briefly introduce their organizations, and then we can launch into our discussion. So, Anthony.
Hi, good afternoon, everyone. My name is Anthony Fortenberry. I use he and him. I am the Chief Nursing Officer at Colin Lord Community Health Center in New York City. Just to give a brief overview of where we are in New York, it's quite good news to share. We are seeing just a precipitous drop in cases here in New York, which had predominantly been somewhat of the epicenter of this outbreak in the United States. And so working very closely with our local Department of Health here, we very quickly ramped up our vaccination efforts and have seen the fruits of those labors over the past month or so. As early as the last 2 weeks or so, we've actually stopped seeing cases coming into our health center, and that is reflected in the numbers that we're seeing across the city. However, now is not the time to stop focusing on MPV prevention, education, and outreach. We want to make sure and get people back in the doors for those second vaccinations to complete this series and provide more education to the community to ensure that we see ongoing trends of a decrease in MPV locally. Thank you so much.
Great, thank you so much, Anthony. And we'll give you a chance to take a breath first before you introduce Colin Lord. So I'm going to invite Matthew to do the honors and start us off by briefly introducing Evergreen Health.
Sure, thank you, Sophia. So Evergreen Health, we are a FQHC lookalike based in Western New York, which is, Sophia mentioned, is primarily thought of outside of our area as the Buffalo region. But we have 5 clinical sites and 1 renovated church, which does become part of our response story based in Western New York. And annually, we service approximately 12,000 patients. And that includes 1,732 persons living with HIV and 1,131 persons accessing pre-exposure prophylaxis. And I mention and highlight that there because in the beginning, that's what we used some of those statistics as an estimate of how many people under our care were likely at risk for MPV, tooled around with those numbers a little bit to figure out like what we would need for likely regional coverage for that initial outbreak. We had talked as we were planning about this about media efforts, and so these are just showing some of the media efforts that were made in Western New York. We had a big media response and a lot of interest from local media, print media, and television media. To the left, there's and this was actually a front page story that featured people from our organization and Dr. Gail Burstein, the Commissioner of Health for Erie County, which is the most populous of the counties in Western New York, talking about the importance of vaccination, but also the difficult message that this was. And we will probably get into that later on, but this was a tough thing to talk about because we had to be honest with people, we had to be clear with people. We are dealing with the scarcity of vaccination, so we had to make sure that we were reaching the people truly at risk, but then not, or doing the best we could anyway to not double down on stereotypes or language that does damage to our communities. And then these are just some photos from our efforts. To the left is the Erie County Department of Health's social media post announcing that we had gotten started with vaccination. Something you'll certainly hear me talk about a bunch during this is that we were, it's more than fortunate. We were, I'm not even someone who usually says something like this, but we were blessed, honestly, to be working with a local health department that was so motivated to do this, that was working on getting ready for this before there were any cases in our region. And then really, as soon as they had access to vaccine, had them out and into arms immediately and were advocating for more to come to our region. In the middle, HRSA happened to be visiting at the time. So HRSA representatives came and saw our vaccine effort, which is at a renovated church, which you'll see on the right side of the slide. Those are some photos of the vaccine efforts in the first phase. And then in the middle, like something we wanted to show to you, which we'll talk about later on, it talks about like how do you get communities on board. And we, with our local Department of Health, worked really hard to get other community-based social organizations involved in getting one message unified out as quickly as possible to reach as many people as we possibly could in a short period of time. So those are all my visuals. Turn it back over to Sophia and Anthony.
Thank you, Matthew.
Yeah.
Anthony?
Thank you. I have just a few slides because I know the real interest here, I think, and importantly, is the conversation around preparing for future outbreaks. But I'll just give a brief overview of Cal and Lord and our MPV response. Pardon me. There we go. So Cal and Lord Community Health Center serves about a little over 18,000 people in New York City, over 4 locations in 3 boroughs, about a little over 100,000 visits. I think we're around 110,000 visits a year. Our services are really targeted towards serving the LGBTQ community, which was, of course, disproportionately impacted by MPV. And so this very quickly became a major initiative for our organization. Just very briefly, again, we really started with staff training as soon as we, in very close collaboration with our New York City Department of Health, to focus on those areas where patients were most likely to have kind of first interaction with the clinic and raising concerns around MPV. So our triage nurses, very importantly, our call center, our front desk staff, and then I'm going to say this again and again throughout this conversation. I have never, in many of our public health responses, we work closely with communications, but with MPV in particular, I don't think that communications was more involved with infection control and clinical operations than during this outbreak over the summer. And we really built some, I think, important infrastructure around ongoing collaboration there. Laboratory testing, importantly, working with, once commercial labs became available for testing, building those networks to ensure lab specimens were being collected appropriately and results quickly obtained. Of course, vaccination, working with the local Department of Health, who initiated vaccination efforts so that we could get our patients who we felt were most at risk for poor health outcomes connected to vaccines. And then, of course, once we were able to get stock ourselves, working in collaboration with the city to be a vaccination site. TPOXX treatment, of course, is for those patients that have more severe MPV infections has very recently, as of last week, been shifted in the way it's being prescribed. And so, this is an experimental treatment for MPV, and the CDC is having a less dispersed effort in getting people engaged in that study. And so, again, I would coordinate with local departments of health or the CDC directly for any guidance around getting patients access to TPOXX. And lastly, and what the last couple slides are around, really communication. As we received evolving guidance, making sure that our staff were up to date, making sure that our website was a good source of up-to-date information, but also community outreach and education using digital media, social media to really make sure patients had access to the information that we had access to in the moment. And so these are just a few examples of that. On the left side of the screen, you'll see some of our digital signage. So this is what was going on in all of our waiting rooms. It was the screensaver in our exam rooms, just to, and I always use this a lot in any discussions that I have around MPV, but just taking the blame and shame out of discussions related to MPV. That was, language utilized in our communications that I thought was really important, as well as doing panels. We had a series of panels. You'll see one example on the right-hand side that was really hoping to get information out into the community beyond our patient base. These are also some social media examples utilizing Instagram. Importantly, Spanish language communications were very important to make sure we were reaching all of the communities that we were hoping to reach with this information. And then you'll see here also, as we rolled out our flu vaccination effort, trying to answer via social media questions about safe vaccination in combination. And I will just share on the right-hand side is a great TikTok that we did around MPV vaccination as well, really trying to leverage trends in social media to capture the attention of the audiences that we felt were most at risk and that we wanted to get in the door. So those are all of the slides, and I look forward to discussing these efforts more.
Great. Thank you, Anthony. So let's open it up to discussion for our discussion. And again, I invite you all in the audience to drop your questions, your comments, and even let us know who is in this virtual room so that we can have a richer conversation during our time together. So we can start. My first question is for you, Anthony. You touched a little bit about on this a little bit, but I wanted to give you an opportunity to flesh this out a little bit more. So Colin Lord is based in New York City, which was the epicenter of the MPV outbreak in the spring and early summer. And so wanted to kind of hear more about how Colin Lord really mobilized to inform the public and open up access to vaccinations from an advocacy perspective, even. And I know you were especially focused on doing outreach in hard to reach communities. Can you speak a little bit about that?
Sure, it's such an important component of our work all the time. But I think in particular with MPV, it required a very nuanced approach. I always use the example of during COVID, our COVID vaccination effort, generally people of older age were more at risk for poor health outcomes. And with MPV, we were trying to target younger people. And so I think it was also an opportunity for us to kind of leverage the communication strategies that we had been utilizing during our COVID vaccination effort, but really look to target a younger audience in this example. I will also say, our patient population tends to be very highly motivated to engage with healthcare efforts around things that are impacting the community, like MPV. These are hard lessons learned from our community regarding the AIDS epidemic, right? And so there is, history in the LGBTQ community around not only mistrust from healthcare system at large, but also a real initiative to take ownership of your own health and get engaged and get vaccinated, in this example, quickly to respond as a community. And so leveraging that, I think, was also important, utilizing our patients. Many of our staff are part of the community that we serve. And so it was about getting information to the people who could also amplify those messages in those harder to reach populations. And so it's a little bit of both and. It's the social media, it's the TikToks, and it's the Instagram posts, and it's the digital media. But I think getting those resources into the hands of our community partners that can really amplify those messages is what made us most successful.
Great. And Matthew, so Evergreen is based in Buffalo and clearly much further away from the main hotspots. So your efforts actually had to were different from the efforts downstate, and so your ability to do rapid response was influenced from your geography and from community perception, even about MPV. Can you speak a little bit about, how your organization sort of had to pivot in different ways to provide information and to advocate for vaccine access?
Sure. Yeah. So being in Buffalo, we are the second most populous region in New York City outside of New York City, but of course are far less populous than New York City is itself. But things that, as much as we were not a hotspot, like something that we are very aware of is the communities are mobile, and summertime is a time of a lot of travel. And then also, even though it's in a different country, Toronto is approximately 70 miles away from us. And the social network and the social sexual network has always been very, very linked, except for the time period where the border was essentially closed. But the border is open now. And so Toronto was not quite as much a hotspot as New York City was, but was one of the international areas of concern. And we are very aware that there's certainly socialization that happens across that border. And so we were watching New York City as part of our own state, knowing that our community is very mobile and traveling around. We were watching Toronto, which we know is just a car ride away, and being really, really aware that it wasn't like a question of like, if this comes, but like when, and like also an awareness too that it would be soon, and preparing for that, but doing so in a way, Anthony mentioned leaving the blame out of it, doing so in a way that really acknowledges what the actual risk is and was. And so as we were getting ready for that, we were learning, of course, as an organization about how this vaccine rollout was going to go. I think many of us were learning a lot about the National Strategic Stockpile and how that all flows, staying in contact with our local Department of Health about like, what will we do? How will we get ready? And when can we expect things to happen? And so in a lot of ways, it felt like a wait and see because we didn't have any supply in our area. And, Anthony mentioned our patient populations being pretty motivated. I agree. We're also talking about something that was primarily impacting gay and bisexual men and persons of trans experience who had sex with men. And it's not universally true, but it's a population that tends to be very concerned about their sexual health and that tends to be more sexually active than the general population. And a difficult fact is like everyone by this time was over social distancing and the impact that was having on sexual activity. And so telling our patients at the time that like the best they could do was reduce their sexual activity, they weren't into it. It's not a popular thing to say. It's not something that people wanted to hear. And it's honestly something that people were, and I don't mean this with any judgment, people were tired of hearing. And so we were working in concert with our local Department of Health and then also with other local community-based agencies so that when the time came, the vaccine was coming to our area, we were ready with a unified message to reach as many people as possible. And so we had a little bit more time to get ready. Our first case was detected in New York State in mid-July. At that time, the best information that our local health department had was that we would be starting vaccination sometime in August. But then through their advocacy, we were able to start that last week in August. So we see, we have never had more than 21 infections in the 8 counties of Western New York. And we truly believe that is resultant of the advocacy of the local Department of Health getting vaccine here quickly and getting lots of it here quickly, and high community uptake, honestly. When people tell me like that the reason the curve goes way down is a combination of vaccine and like extreme behavior change, like I just think that they know like a different set of gay, bisexual males and trans people, people of trans experience who have sex with men than I know. Because like I believe wholeheartedly it was a robust vaccination effort.
Yeah, so I mean, similar to any public health emergency, right? The local, the state, and the federal response has to be sort of in sync, and we definitely learned that from COVID. And actually, it's worth mentioning that we have a number of local public health departments and emergency response specialists in the audience today. And you both touched on, some of the effective strategies that worked in terms of the CBO and the local government agency health institutions that made things a lot easier. I just kind of wanted to sort of twist that around a little bit and give you an opportunity to sort of reflect on some of the particular challenges that you may have encountered that can maybe inform how we think about how to improve this work moving forward.
I'd love to share a specific example that was a collaboration with the City Department of Health. In New York, City DOH rolled out a vaccination effort because everyone wanted to get vaccines in arms as quickly as possible. When you do that, it is very hard to be thoughtful about vaccine equity.
Mm-hmm.
And there was a rush to get vaccines out that could have done better, I think everyone admits, around centering equity. The way that the city, and I very much appreciate their rapid response to correcting course here, is to collaborate with organizations like ours. This is a radical change in the way that the City Department of Health has collaborated with organizations like ours in the past. They created a mechanism for our organization to directly schedule vaccination appointments at their sites throughout the city. And they did this with a large group of CBOs that were serving hard to reach populations within the city that were most at risk for MPV. And so rather than, having this very like only one way to access vaccines from the Department of Health. And of course, this is at the time when only the Department of Health had access to vaccines, right? So unless you were able to take the day off and stand in line all day or refresh your, the home screen of the DOH website, you weren't getting vaccinated. But by working with community partners and creating access to vaccine appointments that were, we had an allocated set of vaccine appointments every day just for our patients or those people in our community that we could get access to those vaccines. And it drastically improved vaccine equity in this effort. And so I think that was one thing that was a very quick lesson learned in this response, and how leveraging those community partnerships can really ensure equity in access to these, at least oftentimes in the beginning, very limited resources.
One of the things that we experienced being a few weeks behind the New York City effort in terms of vaccination was being able to be a little bit more planful around that. And so working with the local health department to involve as many of those agencies, social groups, and community organizations as possible. But then at the same time, we would still be hearing from external sources, like an assumption that our rollout was probably almost the same and that there wasn't any amount of equity. When we looked at the numbers from our first big push, which was about 1,800 people, the proportion by race and ethnicity was actually very close and within percentage points of the census data for our region, which doesn't mean that there wasn't still disparity in vaccine uptake versus actual infections. But when we looked at that, we look at the closeness of the proportions being near the census is one indicator that we are reaching people, at least in a proportion to how we expect them to be represented in the total population. So I think that was an advantage that we had of being able to look at some things that were very difficult that were happening in New York City and being as planful as possible about it. But also we were working with a local Department of Health that was really looking to us as like, you're the largest service provider of medical services for this population in the region. Who do we need to engage with? What do we need to know? What do we need to be prepared for? What should we expect when people are coming in? And they also worked with us on, it was like a leap of faith for them, I think, we take an approach, like we make our vaccine environments like a party environment. So we have like this renovated church, we play loud music in it. And like the first couple of days, I'll admit some of the public health nurses were like, no, the first hour, some of them were like, no, this is not gonna work. This is a serious environment. But like they got right on board with like, this is what your people want. This is how they like it. It's, you know, we're having an environment that people want to kind of stick around in. And so that seems like a simple thing, but we were working really in close concert. And I think they were really looking to us and other organizations and listening about what was going to make it a welcoming experience for people.
Interesting. I actually have a question that's come in that I wanted to share with this group. Just a little bit of a pivot back to some of the themes that you both touched on earlier. I wonder if you can kind of speak to some of the differences in or the nuances in reaching LGBTQ plus populations in terms of messaging around, you know, a public health issue that is has some links to some stigma. And you know, what would a well-planned outreach campaign look like, if you will, if you could kind of speak to some of your experiences on that, and how can we sort of plan for and adjust for this moving forward?
So our organization in the past several years has taken very much like a sexual health focus that doesn't focus so much on, the focus is more on making sure that people have their options and they know what they can do for their sexual health, as opposed to like what the way that it's been before, which is like a disease-based model that looks at these health outcomes as negatives only. I'm not saying there's not negatives within that, but like that way of thinking hasn't worked. And so something that prepared us well, I think, is that through our major uptake in pre-exposure prophylaxis and really like driving out the undetectables and transmittable message, we've gotten our staff and to a degree our patients used to thinking about sexual health as a really good thing. And so we were prepared, I think, as an organization to walk on that line as much as we could. Like we had to be, it's interesting, sometimes we would give media interviews and people would be criticizing us saying like, you're not saying what's really going on. And we actually were, but then the media doesn't know how to deal with that. And so we were talking about like, we had to be honest about like this right now, the reason that you feel like if a gay or bisexual male was saying to us, and this did happen, I feel stigmatized by this message, we had to be realistic about like, yeah, it's lousy being told that we need this the most. It does bring back historical trauma, but unfortunately, the reality is over 90% of these cases are impacting our people. We know that that is because we tend to be more sexually active than the general population. And so we were talking about that really, really honestly and openly, and not as though it was a bad thing, but as though accessing vaccination was something that you could do for forward thinking for your sexual health. I think when it comes to the media processing this message, it was difficult because the media doesn't necessarily know how to talk about the way that our community engages sexually. It's difficult. Like the focus really, not that there's anything wrong with that, the focus in the past many years has been about our community being like the rest of the world or adhering to heterosexual norms. And that makes it difficult to talk about when there's an outbreak and it is impacting your friends who like the general population probably thinks of as married, so they must be monogamous, but they might not be. And so we had to be very, very realistic and honest and also acknowledge feelings that people are going to have about being targeted by stigma, and then also feelings that people who are not part of the risk population for this outbreak might feel about not having access to the vaccinations. We had to like, and the only way to do it was to just like keep focused on like the reason and the truth, and to know that that was the only way that we were going to be successful.
Anthony.
Yeah, I agree with all of that. I also, you know, our strategy, I always feel like the most impactful conversations often happen behind closed doors in an exam room. And so ensuring that our staff had really great talking points was also an important, but the call center needed to be engaged, not just clinicians. You know, everyone in the organization needed to be aware of how language can impact stigma and you know, maintaining a safe place, a safe environment for patients to ask questions and to seek care. I'll also say, you know, just from an epidemiological standpoint, any kind of outbreak is going to begin among a social network. right? And so it wasn't necessary, it could have happened among other social networks. It happened to be the LGBTQ community. And so I think utilizing that as a framework was also really important. And I just could not agree more. It's about providing the facts that this is how this is spreading right now. This is not the only way this can spread. Another important consideration, I think, in urban areas, particularly in the post-COVID world that we're living in, are lots of multi-generational families living together, more so than historically, at least here in New York City. And so the opportunity for transmission outside of sexual transmission was very high. And so also providing that education was important, because while we wanted to make people aware that, we wanted everyone to have the facts so that they can engage in sexual activity most safely, we also wanted to not make this siloed to those behaviors and ensure people knew all of the opportunities of transmission so that they could protect themselves and their loved ones. And so that was really important. And as far as media outreach, I think that was centering that. I mean, I will say most interviews that I did around MPV, stigma came up as a consideration. And I think that working to find language and talking points to anyone in the organization that might be engaging in media efforts, or just talking to a patient or a friend about MPV, was super important. And I give huge kudos to our communications department for helping to craft those messages. I will speak for myself and say, like, once we got some concise language around addressing stigma, those were the talking points that I used throughout the outbreak.
It's very important information. Yeah, very important lesson learned. In the short amount of time that we have left, I just wanted to kind of touch on some of the themes of resiliency in the community, right? And ways that we can really shore up or even recognize some of the ways that the communities kind of came together and sort of supported each other, and how we can build off of that, whether it's through partnerships with other community-based organizations, whether it's with local agencies, health institutions. Based on your experience, what are some of the things that you think that we should kind of build more off of, and kind of strengthen more and think about in preparation for any public health crisis? Anthony or Matthew, go ahead.
Matthew, do you want to go ahead?
Sure. I think there was a lot of confusion about like the vaccine efficacy and this like post-exposure versus pre-exposure. And I think something that helped a lot was that a lot of our patients, a lot of our people who accessed vaccination early, and even some of our patients who, were talking to their friends because they were vaccinated because they were a contact afterward. I think there was a lot of confusion about like the post-exposure versus the pre-exposure tactic. And like people felt the confusion about this, like, wait, if I'm exposed and I'm vaccinated within a certain amount of time, I probably won't get infected, but like, I don't have peak protection for this amount of time. Like, what does it actually mean? And like, in reality, those were questions that people had for each other because they were mitigating and thinking about their own risk and their own risk calculation. And that's difficult. It's difficult to talk to a medical provider about. Like I joked before about like how when people tell me it's behavior change and vaccination, I'm skeptical about that. I think that's something that has been hard. It was hard, I think, for many of the people most impacted to tell the clinicians, no, the reason I'm asking is because like I want to know what I can do tomorrow. And that's, I think, hard to ask a clinician. And so I think that in this situation, we saw a lot of our population like reading that information like 200 or 300 times, really committing it to memory and having really deep conversations about what does it mean and like what decisions am I going to make around that. And I think everybody, I think that was helpful, I think, and that people really like took information that was very confusing and had, I think, really deep discussions about like, this is what we know, and we all have to make our own educated and informed decision about how we're going to move forward. And that might mean sexually socially distancing for the rest of the summer, or saying like, I've had one dose, I understand what that means. this is what I am or am not going to do. And they're the same conversations that we've been having as a community forever, but like suddenly we had something that was like very, very pressing and immediate that was causing those discussions. And so I think a lot of people rise up to the challenge of learning the information and then sharing it.
I would say much of the same. I think something you reminded me of, is an important component for us was really utilizing community champions that could take the message and take it outside of our four walls into the community, and utilizing us more as a resource for clinical support, but not holding all of the responsibility for getting messaging out into the community. And so, a huge lesson learned for me is around maintaining the infrastructure that we created during this response with other community partners. I will also just share another example, and I would love to believe that in future outbreaks, we're not in the same position, but we are in the middle of a really hard healthcare workforce shortage. And so having nursing staff to do the vaccines was such a huge challenge for us over the summer. And so I will say in New York City, like working with other nursing leadership at other community health centers across New York City to just share ideas about how to best use resources, share resources. We had, we were texting each other at almost a daily basis in those first few weeks, just to stay connected, to provide support, to, share homework, not reinvent the wheel, and how to best do this. And I think those kinds of networking, opportunities that happened as a result of desperation can be maintained and should be maintained, because, we always will have, I feel, less resources than demand for what we are able to provide. And so leveraging those relationships that were built during this outbreak, I will say too, I was in such almost daily communication with the City Department of Health, and am so grateful for that support and resource. And I hope to maintain that as well, because, as we say, it's not, if another outbreak will happen, it is when it happens, and making sure that we take all of these lessons learned, not just from MPV, but from COVID, and make sure that we have, we're not surprised. Again, we have Ebola knocking on the door. Just in the last couple of weeks, received notification from the state around preparedness for Ebola. Let's just, utilize these, outbreaks as an opportunity to maintain these relationships.
Yeah, that's right. That's right. And so, we've really only begun to scratch the surface around this topic of, collaboration, cross-sector collaboration and preparedness. And before we sign off, I really wanted to give you both an opportunity to summarize some of the key lessons that you've learned from your experience around MPV, so that we can bring these lessons back into our own communities, so that we can be better prepared for future. And so you sort of touched on some of these things already, but is there anything else that you wanted to share to the group?
I think what Anthony said about maintaining those relationships that developed is important. I mean, sometimes I think we do our best learning during an emergency, but we should carry it forward. But there's things that we decide to do during an emergency that if we tried to plan for in a drill, we might be like, oh no, we couldn't possibly do that. But we were in a situation where like our local Department of Health was staffing a clinical service at one of our non-clinical sites. And it's like the type of thing that like sounds like it could have a lot of problems, but it had almost no problems. And that was like I look back, like even when I was like gathering up photos for this, like I look back and think about like how quickly, like we didn't know each other, not well anyway, and like how quickly we were like working in concert, we'd have like daily like check-ins between vaccine efforts, and like morning of check-ins about like, okay, we've had these call-offs, we're down this staff, and us saying like, okay, we don't have, like Anthony, we don't have any nurses, but like we can send this many more people over to do wayfaring, to help with registration, to all of those type of things. And so I think we do a lot of our best learning when there's an emergency. But what Anthony said, it does resonate, because it can be hard. Then the next emergency comes and you feel like you're starting over again. I think something that I definitely think about a lot in this response is like, the facts are so important. And we live in such a time where there's like not good information and it's hard to know where to trust information. But then it's also like a time where a lot of assumptions get made and it's not helpful to make those assumptions. And so like when we talk about, you know, our proportions for race and ethnicity, like even while we're seeing that the numbers indicated that the proportions were similar to our population as a whole, a lot of people were saying like, but there's no one from this population accessing it. And it wasn't true. And it's not ever to say that there's not always more work to be done, but putting out a message like that, I think is disheartening to the entire thing, but then also isn't sending a message to those priority populations that yes, other people from the population are in fact doing this and thinking that it's safe. And so I think that something that's reminded me of is like, it is always going to be important to make sure that the people most impacted with the most difficulty accessing are reached, but we should be realistic and celebrate the progress that's made toward that and when people are really engaging. And so I don't mean at all to not keep on talking about those things, but to make sure that we are focusing on the facts around all of those things, and including just how effective these efforts were. Like I don't know about you, Anthony, but like I mean we're all traumatized by COVID, right? But like when this was happening in July, I thought we'd still be like in the crux of this right now. And when I look at those like rolling averages, I kind of can't believe it. You know, like I mean, I see it, I look at it every day. I know what we've all done. It feels really good, but like it's hard to believe. But I think it does show like what is possible.
Thank you for that. I could not agree more. And, you know, something that you said that really resonated with me was just around this kind of like infectious disease fatigue that not only our patients experience, but I think healthcare providers as well. And one thing that was something I try to keep very top of mind, and I have been, you know, for a while now since COVID, but I think importantly this summer with MPV is just burnout among our staff and among the people that are leading these efforts. You know, it's important to record all of the lessons learned and like concretize some policy and then share and educate. And it's like with what bandwidth, right? And so taking care of the team that are leading these efforts and providing support around, you know, codifying those lessons learned for the next generation of leadership that's going to be managing this is super important, I think, in resource allocation decisions. And then just burnout in general for your staff. Our nurses that have been doing vaccination efforts, you know, starting, you know, with COVID, and in the last few months, we were doing MPV, COVID, and flu vaccinations all in one setting. You know, it's a lot. And so making sure that we acknowledge that with the staff, that we leverage the available resources of support and create an awareness around burnout, the real implications that burnout can have on staff and patient care is an important, you know, it's always an important lesson learned, but I think right now we have an opportunity with numbers trending in the way they are around MPV to lift that up.
Absolutely. Thank you so much. And so I wanted to ask everyone to please join me in thanking our panelists, Anthony Fortenberry, Matthew Crean Higgins, for sharing your experiences and for offering some insight on ways that we can really support and strengthen our community's response. And I'd also like to give a big shout out to Donnie Roberts, Senior Director of Development and Communications at Colin Lord, and Stephanie Fung, Communications Officer at the New York Health Foundation, for their help in putting this webinar together. And I want to thank you all, the audience, for joining us today. If you'd like to revisit today's webinar, a recap will be posted on our foundation website, which is www.newyorkhealthfoundation.org. And thank you again, and I hope that you enjoy the rest of your day. Thank you.